discuss the results of a phase 3 study evaluating mirvetuximab soravtansine versus investigators' choice of chemotherapy in platinum-resistant advanced ovarian, primary peritoneal, or fallopian tube cancers with high folate receptor alpha expression. Dr. Kathleen Moore, Associate Director of Clinical Research and Co-Director of the Cancer Therapeutics Program at the Stevenson Cancer Center at the University of Oklahoma, will present the study. Dr. Moore?
Thank you, Dr. Graylow. And good afternoon, everyone. Thank you for joining us today. It's my great pleasure on behalf of my international co-chair, Dr. Atun Van Gorp, other international collaborators, and the sponsor, Immunogen, to present this overview of the MIRASOL trial. What I'm going to present today is practice changing. There has never been a presentation or a clinical trial of a novel agent in the platinum-resistant ovarian cancer space that has demonstrated improvement in overall survival until now, and I'm pleased to present that study. Mirvetuximab soravtansine is an antibody-drug conjugate that targets folate receptor alpha and is conjugated to a highly potent microtubule linker, metazanine, called DM4. Folate receptor alpha has been of interest to us in ovarian cancer for a long time. It's almost ubiquitously expressed on high-grade serous ovarian cancer and highly overexpressed in about 35% of cases. Proof of principle for mirvetuximab has already been demonstrated based on the single-arm SORAYA study, which was presented in November in 2022, which demonstrated a response rate of 32% and a duration of response of almost 7 months amongst a population of patients with platinum-resistant ovarian cancer that was folate receptor alpha high and also, importantly, had to be bevacizumab pre-treated for that particular trial. That study, the SORAYA study, led to accelerated regulatory approval in the United States in November of 2022. MIRASOL is the confirmatory global randomized phase 3 that is poised to result in global approvals, hopefully forthcoming. This is the schema for MIRASOL. It is an open-label phase 3 randomized study. Patients had to have platinum-resistant ovarian cancer with folate receptor alpha high expression. This was defined as at least 75% of cells having 2 to 3 plus intensity and staining, and this was done centrally. They had to have 1 to 3 prior lines of chemotherapy, and prior bevacizumab and prior PARP inhibitor were allowed, but were not required except in the setting of a known BRCA mutation. Patients were randomized 1-to-1 to receive mirvetuximab, 6 milligrams per kilogram adjusted ideal body weight, as compared to investigator's choice chemotherapy, which included paclitaxel given weekly, pegylated liposomal doxorubicin, or topotecan. And the stratification factors included the number of prior lines of therapy and the selected investigator's choice chemotherapy. The primary endpoint is investigator-assessed progression-free survival, and then the secondary endpoints were evaluated in a hierarchical fashion, including overall response rate, overall survival, and then, of course, patient-reported outcomes and the other secondary endpoints you can see listed below. Tomorrow morning, I will be presenting the progression-free survival, overall response rate, and safety. Subsequent exploratory endpoints will be presented at subsequent congresses. This is the baseline demographics for the patients enrolled on the MIRASOL study. And things that I want to show you is that about 62% of patients had prior exposure to bevacizumab, and about 55% had received a prior PARP inhibitor in line with current authorizations. The stratification factors that I mentioned are listed here, and so patients with 1, 2, or 3 prior lines of systemic chemotherapy were eligible and represent 14, 40, and 46% of in randomized patients respectively. I do apologize that my boxes are off. And then you can see for investigators' choice of chemotherapy, which was weekly paclitaxel, pegylated liposomal doxorubicin, or topotecan, there were 41, 36, and 23% of patients respectively. So this is the primary endpoint. I'm going to start with the Kaplan-Meier curve for the investigator's choice chemotherapy arm, which has a median progression-free survival of just about 4 months. This is very consistent with what we expect based on historical benchmarks and very consistent with the statistical assumptions made when the study was designed. Here is the curve for mirvetuximab, with a median progression-free survival of 5.62 months. This is a hazard ratio of 0.65 and a p-value less than 0.0001. There are 35% reduction in the hazard of progression or death with use of mirvetuximab as compared to investigator's choice chemotherapy. And what I would like to point out is this point right here. What we see on almost, I will say every study in platinum-resistant ovarian cancer is that at least 50% of participants progress at the first disease assessment, usually on both arms, and come off of study. And you see that here in the investigator's choice curve. But you don't see that in the mirvetuximab arm, where there's a bump out, an early separation, as was alluded to in one of our prior presentations, that is important, and that separation continues throughout the Kaplan-Meier curve seen here. Because this was positive, we could move alpha to overall response rate, which I'm demonstrating here, which is 42 versus 16%. Highly statistically and clinically significantly better for mirvetuximab versus investigator's choice chemotherapy, with a difference of 26.4%. I'm showing you the waterfall plots, honestly, just because I love to look at them. These weren't statistical analysis, but they just show more of the clinical benefit of mirvetuximab versus investigator's choice chemotherapy, where you can see in 80% of patients randomized to mirvetuximab, they had some decrement in their tumor measurements as compared to only 55% of those randomized to investigator's choice chemotherapy. More importantly, because overall response rate was positive, we could move alpha to overall survival. Overall survival was planned as an interim analysis at the time of progression-free survival, with a boundary set for statistical significance of 0.0131. At the time of this analysis, we had 13 months of follow-up, and 68% of final overall survival events had occurred. Here's the investigator's choice overall survival curve, with a median overall survival of 12.75 months, very consistent with what we would expect from historical benchmarks. And here's mirvetuximab, with a hazard ratio of 0.67 and a p-value of 0.0046. And so this represents a 33% reduction in the hazard of death for patients who receive mirvetuximab as compared to investigator choice chemotherapy, and this is both clinically and statistically significant. This is a high level of the safety for patients enrolled on the MIRASOL study. I will show you there were less grade 3 or higher treatment emergent adverse events, less serious adverse events, and markedly fewer discontinuations from assigned therapy due to treatment emergent adverse events. Looking more granularly at the adverse events seen in the mirvetuximab versus investigator's choice chemotherapy, we can see for hematologic toxicities, there were really almost none. These are negligible with mirvetuximab, which helps patients tolerate this therapy who've had prior lines of therapy with hematologic toxicities. We see no alopecia and less peripheral neuropathy than seen with the closest comparator, which would be paclitaxel. We see about the same rates of low-grade nausea and diarrhea, which have pre-specified mitigation strategies which are successful in this space. And as previously described in the many studies of mirvetuximab, our key toxicity is ocular disorders such as keratopathy, dry eyes, and blurred vision. This happens in about 42% of patients, is of low grade, and there are well-specified preventative and mitigation strategies that result in patients being able to stay on this therapy with reversible eye toxicity, and only 4 patients on the entire study discontinued due to ocular-related events. So in conclusion, mirvetuximab is the first novel treatment to demonstrate a benefit in overall survival in platinum-resistant ovarian cancer in a phase 3 setting. The MIRASOL study demonstrated statistically significant and clinically meaningful improvements in progression-free survival, overall response rate, and overall survival as compared to investigator's choice chemotherapy, and continues to demonstrate a differentiated safety profile consisting predominantly of low-grade ocular and gastrointestinal events. This is the first antibody-drug conjugate approved in ovarian cancer, and the only biomarker-selected therapy available for platinum-resistant ovarian cancer, and only the second biomarker-directed therapy after PARP inhibitors for ovarian cancer. And these data we consider to be practice-changing and position mirvetuximab to be the new standard of care for tumors that are folate receptor alpha high and platinum-resistant for women with ovarian cancer. I'm indebted to the women who participated in the study, in all studies of mirvetuximab, over 1,000 of them, and I hope that they are proud of these results. Thank you.
Thank you, Dr. Moore. And now we'll invite ASCO expert Dr. Mary Jennifer Markham to make a few additional comments about the significance of this research.
Thank you. This is really important for our patients, and I just want to make that context very clear. Women who are diagnosed with ovarian cancer, fallopian tube cancer, primary peritoneal cancer, and I will use ovarian cancer moving forward in my comments because they are all together. When they have recurrent disease, these women all head down this pathway that ultimately ends up with platinum-resistant disease. And these are cancers that are, as the word says, resistant, not just to platinum, but they are resistant over time to really anything that we give to them. So a woman facing this diagnosis of now recurrent disease, platinum-resistant recurrence, is also still facing the fact that she may have side effects from prior therapies, so prior neuropathy from her taxane therapies. These women are desperate for something new, and it's been almost 10 years since there's been anything new approved in the platinum-resistant setting, and that was bevacizumab back in 2014. So this is very novel, very much desired. We teach our oncology trainees that the right answer for treatment for a platinum-resistant ovarian cancer patient is actually clinical trial. That's the right answer, because our standard of care chemotherapies are not cutting it. So this study, the MIRASOL study, is practice changing for this population of women who have platinum-resistant ovarian cancer and this folate receptor alpha high expression. I think just a couple of other comments. These women ultimately may need their standard chemotherapy, but this allows the delay and postponing of those toxic treatments that we know have a very poor survival curve. You just saw the curves on this slide. Delaying therapy is great. Women are happy to delay toxic chemotherapy when they're dealing with this diagnosis. They've been waiting a long time. These women have been waiting a long time for progress, and I think this MIRASOL study is progress. We need more of it, and I'm really pleased that I'll have a new drug to talk to these particular patients about.
Wonderful. So we'd now like to open the floor to questions.